Welcome guys to another series today on the bones of the upper limb. So we're talking about the radius. So I've taught you about the clavicle, I've taught you about the scapula, and I've taught you about the humerus. So watch it one step at a time. It's also easy. So this will push you into the muscles of the upper limb. So after the bones, you go to the muscles of the upper limb. I'm giving you one step at a time. You go to the space, from the space go to the nerves and vessels. So small you understood everything like that. So in the radius bone today specifically, so the radius bone is also a long bone, just like the humerus too. So we have long bones, but the clavicle is the only long bone that is horizontal, while the rest are vertical. So we have talked about the humerus. So the humerus is also articulating with the radius bone, and the radius bone is the lateral bone of the forearm. So if you are looking at your forearm now, the bone in the lateral part is called the radius bone, but now it is homologous to the tibia. I get it. It's homologous to the tibia in the middle part of the leg. It's homologous to the tibia because the tibia is strong. Same thing with the radius bone. Homologous to the tibia. Why the humerus homologous to the femur? Don't forget. Know the bones like that. Now, since we know that part now, what is the part of the radius bone? Now, in the humerus, we have the upper part, we have the shaft, we have the lower part. In the humerus, you have the upper part, shaft, and lower part. Same as the radius bone. Now you have the upper part, shaft, lower part. You are seeing it on your screen. So important now in the upper part, what can you see? Same thing. Humerus, you can see the head, you can see the neck, greater and lesser tubercle, you can see the intertubercular circles, but this one is quite different. You can see the head, neck, radial tuberosity, head, neck, radial tuberosity. In the shaft, you can see the shaft is joining the upper end and the lower end. You get it now? So it's very important because you have the sharpest border, which is the interosseous border, is in the medial side of the shaft, which we'll also talk about. Now, you see in the lower end, what can you see? The lower end has the styloid process. So the styloid process is very important because it is articulating with the carpal bones. Are you getting now? It's articulating with the carpal bone, the styloid process. So it encompasses all the whole carpal bones. But in the dorsal part, you have what you call the left side tubercle. So you can palpate the left side tubercle in the lower end, the posterior lower end of the radius bone. You get it now? So also very important now. So you should know that the head of the radius bone articulates with the capitulum of the humerus. The head of the radius bone articulates with the capitulum of the humerus to form a humeroradial articulation. Again, I told you in the lower end of the humerus is the capitulum, and above the capitulum is the radial fossa. So that capitulum now attaches or articulates with the head of the humerus. You get it now? So in that place too, you can also see the annular ligament. So the annular ligament is located in that direction. So now in the neck is the constricted part of the head. So you see the neck now. You see when you go down from the head, you go down, you see a constricted part called the neck of the radius bone. Are you getting now? And it is embraced by the lower part of the annular ligament. It is embraced by the lower part of the annular ligament. And there's also a quadrate ligament there. A quadrate ligament is attached to the medial side of the neck. So if you go to the medial side of the neck, you see an attachment there, what we call the quadrate ligament. So the quadrate ligament is attaching to the medial side of the neck. You get it now? So you see the dotted part of the bones you are seeing there, that is the neck of the bone. It's the constricted part of the head. You get it now? So I've given you the head, I've given you the neck, I've also given you the quadrate ligament that is attaching to the medial side of the neck. The next one is the radial tuberosity. So the head is attaching to the capitulum, the neck is the constricted part, and the medial side is the quadrate ligament. So be following me. It's very important though. The radial tuberosity, what is attaching to the radial tuberosity? Very important is the bicep tendon. So the long head of bicep is originating from the supraglenoid tubercle. The short head of biceps is originating from the tip of the coracoid process. So they form a belly and they passes through. Now when they pass through the cubital fossa, they're using the bicep aponeurosis passing to insert on the radial tuberosity. So bicep tendon insert on the radial tuberosity. Don't forget the bicep tendon. If you go to the muscles, you will see them there. Very important. Through the biceps aponeurosis. Now if you go to the borders now, which is the shaft, very important. What can you see there? in the shaft. Now you can see the anterior oblique line, you can see the posterior oblique line visible. You will the anterior oblique line and you see the posterior oblique line. These are also very important landmarks, because in the anterior oblique line, that is where the radial head of the flexor digitorum superficialis is originating from. The radial head of the flexor digitorum superficialis, which is the muscle of the anterior compartment of the arm. So it's a superficial muscle which is inserting on the fingers. Are you getting it? It's inserting on the fingers. So flexor, anterior compartment, digitorium, digit, fingers, superficial means is a superficial muscle. So in the anterior compartment of the forearm, you have the superficial muscle and you have the deep muscle. You get it now? So the flexor digitorum superficialis is located in the superficial. You get it now? Coming from the anterior oblique line. Don't forget. The posterior oblique line is also very important. It's in the posterior part too, just from the radial tuberosity. So from the radial tuberosity in front, if you draw a line, it's called the anterior oblique line. If you draw a line at the back, it's called the posterior oblique line. But the anterior oblique line is the origination of the radial head of the flexor digitorum superficialis. Now in the medial border, now you have this very sharp. The medial border is very sharp. Why is it very sharp? Because it is attaching the interosseous membrane. So you have the medial border or the interosseous border, which is very sharp, which is attaching the interosseous membrane with the lateral border of the ulnar. The lateral border of the ulnar attaches the interosseous membrane together with the medial border of the radius. So the interosseous membrane is attaching the two bones in the middle. Then the interosseous membrane is attaching the lateral border of the ulnar and the medial border of the radius. So you have the anterior oblique line, you have the posterior oblique line, you have the medial interosseous border. Then now you also have the surfaces. Now the surfaces is just for the origination of the flexor muscle. So you have the one that's originating from the upper to fourth, which is the flexor pollicis longus. So you can see there, you on the lower 1/4. Now the upper to fourth is for the flexor pollicis longus. The lower 1/4 is for the origination of the pronator quadratus. Now the flexor pollicis longus is the muscle of the deep compartment of the forearm. In the anterior part, you have 3 muscles that are in the deep, while in the superficial you have 5 muscles there. So total 8 muscles in the anterior compartment. So in the upper to fourth you have the flexor pollicis longus. In the lower 1/4 you have the pronator quadratus. While in the middle, between the flexor pollicis longus and the pronator quadratus, you have the nutrient foramen. The nutrient foramen is where the nutrient artery supplies the bone. Where the nutrient artery supplies the bone. So if you remember what a nutrient artery is. The nutrient artery supplies nutrition to the spongy part of the bone. And where the spongy part of the bone, of the radius bone. Also the humerus also have a nutrient artery. Are you getting me? It also have a nutrient artery, which is a branch of the brachial artery. But the radius artery have a nutrient artery from the anterior interosseous artery. Don't forget. Now for the posterior part, now you have the abductor pollicis longus. Now the posterior part of this bone marks the origin of the extensor muscle, while the anterior part marks the origin of the flexor muscle, or muscle of the anterior compartment of the arm. Now very, very important, in the lateral surface now you can see the supinator there. The supinator is coming from the upper 1/3, while the pronator teres is coming from the lower 1/3. So very, very easy. You are seeing it. I'm showing you on your screen, you are following it. Yeah, I'm showing you on your screen, you are following it. What can you see in the lower end? Open your eyes very, very well. The lower end is a wide part of the bone. So what does it have? If you are seeing the lower end, in the anterior surface of the lower end, what are you seeing? Now it marks the attachment of something called the palmar radiocarpal ligament of the wrist joint. So the wrist joint now is formed by the radius bone and the carpal bone. So the radius bone is covering the carpal bone, forming the radiocarpal joint. And the radiocarpal joint now in the anterior side, if you open your palm now, this is what they call palmar. At the back it is called dorsal. At the front you call the palmar, at the back you call it dorsal. In the palmar side you have what you call the palmar radiocarpal ligament of the wrist joint, which is crossing the anterior surface of this bone, while in the back now you have the dorsal listal tubercle. You have the dorsal listal tubercle. The dorsal listal tubercle is a groove. The dorsal listal tubercle is a groove. You can see it now. The dorsal listal tubercle is a groove. which transverses by the what extensor pollicis what longus. So the extensor pollicis longus transverses the what Lister what tubercle, or you call it the dorsal tubercle of Lister, or Lister dorsal what tubercle. Bordering the dorsal Lister tubercle, you can see all these muscles which you can see there, which is the extensor carpi radialis longus and extensor carpi radialis longus brevis. Extensor carpi radialis what brevis and longus. So the extensor carpi radialis longus and brevis transverses to the edges of the what Lister tubercle. Hope you are understanding it now. So first of all, you can also see the styloid process. So the styloid process is what you can see. I told you that the styloid process is what covering the carpal bones, forming the radiocarpal joint. The radiocarpal joint forming the what wrist joint. So the radiocarpal joint is formed majorly by the wrist joint. Don't forget. So now that styloid process is very, very important, because at the base of the styloid process, the brachioradialis is what inserting there. The brachioradialis is what originating from the lateral supracondylar ridge and it's inserting on the what base of the what styloid process. Don't forget, which is the brachioradialis do not cross the wrist joint. Either it is inserting on the what base of the styloid process, while the tip of the styloid process is attaching the radial collateral ligaments of the wrist joints. Don't forget. The next thing is the ossification. So how many centers is this people ossifying? It's ossifying by 3 centers, 1 primary center and 2 secondary center. 1 primary center is also in the shaft, very, very important, while the secondary center 1 above, 1 below. And the same thing, the primary ossification center is by the 8th week. So only the clavicle is by the 6 to 5 week, or 5 to 6 week rather. Only the clavicle is by 5 to 6 week. Others are ossifying in the 8th week. But sometimes in some texts you can see that the scapula ossifying in the 7th week. So open your eyes. Everybody 8th week except from the what clavicle. So 1 secondary center up, 1 secondary center down. Very, very important, very, very sweet. You get it now? Now the first upper end ossify in the 5th week, the lower end ossify in the 1st week. So they ossify by what we call endochondral ossification, except from the clavicle. All bones, all long bones undergo what we call endochondral ossification, but the clavicle have 2, membranous in the shaft and what endochondral ossification in the medial end. You have understood it. Now what is the clinical scenario here? Just like the humerus, I say there's 3 fractures that can undergo there, but also the radius bone. Also know that all long bones can fracture easily in the shaft. All bones have what shaft fracture. So you have the radial shaft fracture, you have the humeral shaft fracture. But humeral shaft fracture damages the what radial nerve, while the radial shaft fracture damages some of the muscles that are passing there. Don't forget. So the supinator muscle might be affected, the pronator teres might be affected, the bicep might be affected. So any of these can be affected, because the radial bone is a weight bearing bone of the forearm. So it is very strong bone of the forearm, because it's the only bone that is attaching to the carpal bone, forming the what palmar, forming the radiocarpal what joint, or you call it the wrist joint. Now you also have what you call Colles fracture. So you can see it in your screen. You have the Colles fracture. Now you have Colles fracture and Smith fracture. So the opposite of Colles fracture is Smith fracture. You get it now? But Colles fracture, now you are fracturing the distal end of the radius, not the styloid process, the distal end of the radius. So you have a proximal end or the upper end, you have the shaft, you have the distal end or the lower end. So when you fracture your lower or distal end towards the styloid process, if you fracture that place, you have what you call Colles fracture. But now in Colles fracture, now when you fracture that distal end, the bone will move what upwards and what backwards. In Colles fracture, up and back for Colles fracture. But why for Smith fracture, it will move what forward and what downwards, forward ever, downwards, forward, downwards, while Colles fracture move upwards and backwards. Therefore, if you fracture your styloid process of your radius, you call it what Chauffeur's fracture. Chauffeur's fracture. Don't forget. Now the radius bone is usually fractured in people above what 50 years old, because the bones start becoming what weak. Get it now? Start becoming weak, and it's usually fractured when you fall with an outstretched hand. Get it now? So very, very important, very, very simple. Hope you get it now. Now, hope it all made sense. I hope it all made sense to you and you have understood everything I talked about. So you look at the bone, follow what I said, write it down. It's not hard. If it's fast for you, you can slow it down, but it's very, very simple because I'm trying to summarize the bone. So I started from the upper end where you can see the what? I started from the upper end where you can see the head of the radius, you can see the neck, you can see the radial tuberosity. In the shaft, I can see the oblique lines, I can see the surfaces and the interosseous border. Below, you can see the styloid process, dorsal listed tubercles. Very, very easy. So I hope it all makes sense to you and you understand it. Make sure you share it to all your friends. Make sure you watch the video. Make sure you understand. If you don't understand or you want me to make a video for you, put it down in the comment section. I promise you when I look at it, I'll send it for you or I'll make it for you. So I'll be seeing you in my next video on the bones of the ulnar, or call the ulnar bones. Bye bye.